Hey everyone, Dr. James here, and as many of you may know, I am a first-year family medicine resident doctor. So just as a bit of background, in my 3-year program, for our first year, we go through a series of month-long rotations on different services. It could be pediatrics, surgery, even some electives, or also what we call inpatient medicine, which is pretty much a hospitalist work. And if you don't know what either of those means, it's pretty much when you take care of all the patients who get admitted from the emergency department to stay in the hospital for a prolonged period of time until we deem that it is okay for them to return home. So just generally speaking, classically, this is known to be one of the harder rotations, if not the hardest rotation. And pretty much you're working 12-hour shifts at a time, working weekends, and sometimes even going 8 days straight out of the month. And yeah, I kid you not, by the last week of this month-long experience, I was literally dreaming of putting orders in for patients and making diagnoses and all that good stuff like every single night in that very last week. It was a lot. So without further ado, ladies and gentlemen, I'll be sharing with you what it was like and some reflections of my experiences as a resident physician doing the inpatient hospitalist work for the very first time. All right, so as I kind of mentioned, as a hospitalist, this is the flow. So you generally wake up very early in the morning, you review the charts of all the patients that you're in charge of. We call it running the list, and you look at their vital signs, you know, like if they had any fevers overnight, if their blood pressure is okay. You also review the medications to see if all that is fine, and you look at any labs that were taken, such as electrolyte levels or even biopsy results, and you look at recommendations also, because sometimes you ask for consults from other specialists, such as like a cardiologist, to see what recommendations they have for the management of the patient. You take that into consideration, and then you move on to the rounds portion. And that's where you actually go and see the patient each morning, bright and early. You kind of feel bad like interrupting them from their beauty sleep. And in many programs that are teaching hospitals, they'll actually have the med student go in first, and then the resident, and then the fellow go, and then the attending doctor finally waking up the patient and literally asking the same questions, like, how did you do last night? Is everything okay? Blah, blah, blah. But I mean, you get more eyes laid on you, so like fewer things fall through the cracks, but it's one of the things that's very common. Let me know if you were ever hospitalized in a teaching hospital, and let me know what it was like to be asked the same question 5 different times by 5 different people. So anyways, we run around the hospital all over the place, asking the patients how they were doing, blah, blah, blah. You saw everyone, perfect. And now as a resident, you come up with a game plan for the day of what you want to do to manage this patient. It's like a medication that you want to give because you saw this or observed this, or the patient's complaining of vomiting, so you want to get an x-ray of this, something along those lines. And so you make a plan for each and every one of the patients under your care. And because this is a residency program, as a resident, I have to propose all of these ideas to my chief doctor, called the attending, and the attending will either approve or suggest maybe some changes to the plan. And then once all of these ideas are finalized, that's when the rounds are officially over. So we stop talking about all the patients on the list, and we can start putting in those orders. And then throughout the late morning and early afternoon, we're writing progress notes so that everybody in the hospital could know what our ideas are, what we are managing. And then also, as patients come in through the emergency room, we get calls from the emergency room doctors to accept patients under our care. So that phone call that we get from the emergency room doctor to bring one of those patients from the emergency room under our care, and that's what we call a patient admission. So in order to formally admit a patient, as a hospitalist, you actually have to go down to the emergency room and meet the patient for the very first time and get a thorough history about what's been going on with the patient. Also, you got to read up on their chart and from their medications that they're currently using, because sometimes things on the computer are old or outdated and you just need to get everything up to speed. And actually at this point, when I'm at the emergency room, a lot of interesting things actually happened. I had a patient who, as I was reviewing the list of medications and stuff like that that they were taking, I saw lidocaine cream as one of the things, and I asked, I see you're taking lidocaine cream, sir. Is there any particular indication as to why you're taking this? Lidocaine, by the way, is a numbing agent. We use that in various forms. Many of you are probably aware that we use it as injections before doing any cutting or anything like that in certain like surgical procedures. So I was very interested as to if this patient was actually taking a cream with lidocaine in it And if so, why? And he just looks at me and says, yeah, I use it as lotion. It keeps my skin moisturized. And I was like, you know, that's probably not a good idea, especially as lidocaine, you know, it kind of loses that numbing effect if you use it on constantly. So that's a pro tip. Any guys using lidocaine patches, always got to leave a little time frame of not having it. Another interesting thing I noticed when I was doing the initial assessment in the emergency room was when a patient came in and I asked him if he drank or smoked or anything like that. He said hard no to both. And I said, you know, do you drink alcohol? He said, absolutely not. His general condition and his lab work kind of was suspicious for alcohol use, like chronic alcohol use, mind you. And then I pressed him on a little bit about it. And I asked him, are you sure you don't drink any wine? And he said, no wine. How about beer? And he said, yeah, I drink beer. And I was like, whoa. So no alcohol, but beer. So like, how much? And he's like, yeah, you know, like 2 to 3 bottles of beer a day. And I was like, wow, okay. This gentleman was from Guatemala, and I actually had a patient in the clinical setting who also, I ran into the same situation. I don't know if it's a cultural thing. By the way, if there are any Guatemalans watching this, let me know if there's a cultural thing about like beer not being considered alcohol. I'd be curious to know if that's a thing or not. But you know, the devil's in the details when you ask questions. So it's very important for us doctors, not because we're nosy and we want to know everything, but we really genuinely need to know all these answers to these questions to better address the situation. I guess the more detailed you are, the more things you can also end up finding out. So moving outside of the emergency room and when we're actually managing the patients who got admitted to our service, there's a lot of management of medications, looking at and reviewing lab work and managing the patient. It's not really that much hands-on per se, but there are actually a few things that we do. And speaking of that, if there's ever like a patient that we're suspecting that they're bleeding from the inside of their digestive tracts, you would imagine that in this modern era, there's like a special imaging technique that we can do, or any like new lab work marker that we can find that would just give us a straightforward answer if they are or aren't bleeding. But actually, the first thing that you have to do when you do suspect that is a digital rectal exam. So as you can imagine, it's where you put your finger, well, first of all, is where you put gloves and then you put gloves again. We call that double gloving. And you pretty much insert your finger in the patient's anus and feel around and see if any blood comes out. That was a lot of fun. So like suspected digestive tract bleeding is actually something that we see very common. So yeah, it's something that hospitalists have to do a lot. Tend to have a huge sigh of relief once you're off the service that you won't be needing to do that anymore. But a cool thing that I was able to do was a fluorescent stain exam on somebody's eye. So basically when you suspect that something in the air or some particle like scratched the surface of the eyeball, you pretty much put a special dye in the patient's eye and use a blue light and it glows. And if there is like a scratch or something like that, like on the superficial part of the eye, it would line up and you would see it very obviously. And it looks cool because it's a blue light and you see everything glowing, kind of like what you would think like at a bar or a nightclub or anything like that. So whenever I see blue light and things glowing up in that way, I'm always actually now gonna think about eyeballs. But anyway, that's always a little cool thing that we can do. Very cheap, very effective, and you can definitely get an answer right away if things are both either good news or bad news, right? If you have a scratch or you don't in the eye. And then kind of moving on to like a more serious note, this was the first time where a patient under my care passed away. She was an 87-year-old female. Before coming into the hospital, when I saw the notes of what she was like, based on her clinic primary care notes, she was very active. Granted, she had feeding done through a bag here attached to her stomach. But other than that, she was a woman that was very involved in her community and whatnot. And with a simple pneumonia, she deteriorated rapidly. And throughout the many days, which turned into weeks, for the pneumonia component, that resolved, but then it just opened Pandora's box for all the other things in her health to just deteriorate rapidly. And that was something that was hard to come to terms with, because especially with end-of-life scenarios and stuff like that, we tend to forget that, especially with older patients, decline happens not in a gradual sense usually. It's usually something that happens very steep and very quickly. I remember, like, every day I would speak to her son. Her son was in his 50s, late 40s, I would say. And I admired very, very deeply how he was very much committed to his mom, and he fought for her well-being all the time. And you can tell he was very much invested and very on top of things. Something that unfortunately is kind of rare to see grown-up adult children here in the United States when it comes to their relationship with their parents. So it was something that was very sad. It was a wake-up call in terms of how frail life is. But as a doctor, it's kind of like a rite of passage in which that time will come in terms of dealing with end of life and with a patient who's just deteriorating to a point where you sit with the family members and you speak to them about comfort measures, and you weigh the pros and cons about, sustaining life artificially versus giving the most comfort for this patient and honoring what they would want if they were able to express their desires at that moment. So all in all, this inpatient experience working as a hospitalist was something that was very physically and even emotionally tough at times, but it was definitely an experience where I got to learn so much in terms of not only like medicine in and of itself and honing in the practical skills that I developed only as book knowledge as a med student before, but also it was a great experience learning how to deal with other people who work inside the hospital, the social workers, shout out to them, the nurses who give the patients the best care possible with the boots on the ground, and they are definitely overworked sometimes. It's tough. It's a tough world in the hospital setting, especially in a large public hospital, but it's definitely something that builds those clinical muscles that resident doctors need to have in order to be 100% confident in diagnosing patients and managing them accordingly. So that's pretty much some of the highlights. If you want to know a little bit about more topics throughout residency, just type in the comments below and I'll be very much happy to address them. And with that being said, ladies and gentlemen, stay healthy, stay blessed, and until next time.